Good afternoon, everyone. iTech India welcomes all the participants for today's special NDLS session. Today's topic is scaling up services at LAC and LAC Plus centers, and the speaker is Dr. B. Ravi Kumar. Dr. B. Ravi Kumar sir is a public health specialist with more than 2 decades of experience in implementing large-scale public health initiatives. He has worked in close collaboration with the National AIDS Control Organization of the Ministry of Health and Family Welfare, Government of India, as well as various donor agencies. We welcome you, sir, for today's session. A request to all the participants, please keep posting your questions in the chat box. All the questions will be taken up at the end of the session. Over to you, sir.
Yep, thank you. Thank you so much, Vitaji. Good afternoon, everyone. Today's session is scaling up of services at LAC and LAC Plus centers. So, looking at the session objectives, we'll be discussing a bit briefly about the background, how the LACs have started and how the LACs have been scaled up to LAC Plus centers. And the initiatives or what we can say the responsibilities of the LAC Plus centers, how have been redesigned. How do we categorize the patients in various categories? And the objectives and functions of the LAC and LAC Plus centers. We'll try to understand the process of linked in and linked out in terms of the revised the operational guidelines and what are the activities to be taken up by the nodal ART center. How do we monitor the LAC LAC Plus centers? What support does the nodal ART center is supposed to provide to the link ART centers and LAC Plus centers? And what are the standard operating procedures for their ART initiations at the LAC Plus centers? So, as per the revised guidelines, we know that these centers are now are being permitted or NACO has approved for the ART initiations at the LAC Plus center. So, what is that the particular standard operating procedures? How do we do that? The ART initiations, no, that we'll be discussing, and what the reporting and recording format that needs to be kept at LAC, LAC Plus centers, and how do the nodal ART centers also need to keep a track of the recording and reporting that happens at the LAC, LAC Plus centers. And the most important part of the session would be the formation of the community ART refill groups, what we call as the CAR models of the revised guidelines. So this is briefly about the objectives that we'll be going to discuss in today's session of scaling up of the services at LAC, LAC Plus centers. So discussing briefly about the background part of it. So initially in 2008, LSCs were established for no majorly to as the drug dispensation centers, okay, and treatment of the minor OIs and management of the adverse effects and to reinforce on adherence on every visit for the PLHAV. So basically the LSCs when they were formed with an idea of the ART centers are located mainly at the district hospitals or at the level of the medical college hospital. So we didn't have much of an the drug dispensing sites when we talk about the below district levels. So that's how the concept of the LAC LAC Plus have been formed. And and the one more reason was like when we look at the number of ART centers across the country as of now, there might be around 790 odd ART centers and more than 5,000 ICTC centers. So there is basically a significant linkage loss between the testing and linking the patients to the treatment. So this again one of those concepts that has come into picture. So how do we actually ensure that these services can be scaled up so that we can decrease the linkage loss between the ICTs and ART services. So one of the studies that was commissioned by NACO also reflected the reasons for the gaps in the linkage included. So PLHAV being asymptomatic at the time of dissection and the long distance, the travel issues, the time issues, the financial issues, and need for the multiple visits for the baseline investigation. So patient coming all the way from one of the sub-district levels and coming to the ART center. So he has to spend so much of time, and then losing the daily wage and all the issues have come into the picture. So, and again, just to come all the way from that particular area to the ART center and get the baseline investigations on one day, report coming on the second day or third day, depending on hospital, and then no initiating our. So this all these factors were leading to the linkage loss between the ICTC and the ART services. So when you look at nearly 20% of the patients reach ART centers at a very late stage with the CD4 count less than 100, and where where you have the risk of the mortality is very high, around 2 to 3 times. So then the scope of the functions of the link ART centers were expanded to to include the pre-ART care in 2011, and the select ART select link ART centers were upgraded to the link ART centers LAC plus centers. So where you have an high load center, so those were scaled up as link ART plus centers. So when 2017 during 27 when treat all policy was rolled out, so as per this, all the PLHIV were need to be initiated on ART irrespective of the CD4 count. So, and hence, therefore, the LAC plus scheme has been revised to expand the scope of to include the ART initiations at the LAC plus centers. And but this there are certain no selection criteria whether these LAC plus centers can be scaled up as an no ART initiation center. So, but that needs to be there are certain formalities that needs to be completed by the SACs and then the approvals of the NACO, and then the LAC plus centers can be authorized to initiate the ART at those centers. So it's a brief about the background, how the the centers were formed and how the scale up has been made from LAC to the LAC plus centers and now to the ART initiation centers. So patient-centric service across the treatment cascade. So if you look at this particular slide, so this is very clear. And during the recent visits also to some of the ART centers, so it was very clear that most of the centers were not actually categorizing the patients, which were clearly laid out in the national operational and the treatment guidelines. So once the patient is enrolled into the HIV care at the time of the resection, so the patients will be categorized into package A and package B, sorry, package A plus. So which includes in the package A all the PLHIV who were newly registered in the HIV care. No, until 6 months of ART initiations will be under package A. So those people with advanced disease, advanced HIV disease, people with the OIs or the CD4 count less than 200, so they will be under package A plus. So once these people undergo viral load testing at 6 months of the ART initiation, so these people, these PLHV will be categorized into package B, who are considered as virally suppressed or comes under the stable criteria, and package C, who are virally unsuppressed and are categorized as unstable patients. So if you look at this particular slide, it becomes very easy for us know at the ART centers to categorize the patients. So look at the 11 ART number. So based on that, you look at how many people are newly registered. Okay, so they will all come into your category package A. So look at people with no CD4 count less than 200 and otherwise, so they come into package A plus. So you categorize them into package and in A plus. So you also have people who already have undergone viral load testing at 6 months of time or 1 year of time. So who are all virally suppressed, so they will be categorized into package B, and people who are not suppressed, they will be categorized into package C. So this is a very simple criteria which will actually help the ART centers or the LAC plus centers to categorize the patients and decongest the ART centers so that you can focus more on the unsuppressed PLHIV or unstable category of those particular patients. Okay, so this is the patient-centric services across the treatment cascade, which needs to be followed by each and every ART center and the LAC plus centers. So you look at the packages. So we look at what services need to be provided for at the time of initiation and for the short-term retention, and what are the package of services that may be provided for the long-term retention. So the package A, we know that the new patients are being enrolled into the ART center, newly registered patients. So the routine process of providing the the address verifications or the phone verifications, and you identify your caregiver, screening for the OIs, and you talk about the rapid ART initiations within 2 to 7 days of getting registered at the ART center. Then you categorize, you also look in whether the patient is 4S negative, then you look for the TPT prophylaxis that needs to be given. If the CD4 is less than 350, then you talk about the patient is eligible for the CPT prophylaxis. Okay, and then you also give an additional responsibility for the CSC to ensure that the patients are being tracked up for all these new patients for initial 6 months so that they don't become miss an LFU. And then after that, then you provide the viral load testing, which is no scheduled at 6 months for the new ART initiations. And then based on that, then you also categorize the patients with the patient is suppressed or unsuppressed, then suppressed, then goes into the package B, unsuppressed comes into the package C. Then you also provide the index testing for that the source patients, index testing of all the spouse, partners, and children's. for that particular patients, and the patient-centric package, especially for the KP populations, adults, children, and the pregnant women. So we have been discussing more about no the children and the pregnant women, which again is the main point that needs to be discussed here in this particular slide, that we provide the viral load testing for the pregnant women at 32 to 36 weeks of pregnancy. That is the most important thing that needs to be followed up when you talk about no, the new patient, new ART registrations. So one of the doubts that usually come when we talk about the provision of the viral load testing for the pregnant woman. So it has been clarified in many of the sessions and even at the centers. So even it's a mandatory, this is a mandatory viral load testing at 32 to 36 weeks of pregnancy. Even though patient has been newly enrolled, so it is a mandate. The pregnant woman has to undergo viral load testing at 32 to 36 weeks of pregnancy. So this actually gives us an idea of risk categorization based on the viral load result. So this is the most important part. So please keep this important point in mind, because we have seen a lot of gaps in terms of viral load testing of the pregnant woman. So when it comes to the, I'm sorry, and I forgot about the children part of it. So children, again, the most important point is, so child dosage has to be adjusted based on the weight band. So these are some of the gaps that were observed. So these are the points that needs to be kept in mind when you talk about new patient registrations at your centers. So package A plus includes the people who are there in the package A plus the advanced disease management. So people with multiple, I mean, the OI is part of it, or the CD4 less than 200. So additional counseling, adherence counseling has to be provided for these particular patients. So when we talk about package B, as we discussed, the package B includes those particular patients who are virally suppressed, so which might who fall on the category of stable criteria. So they will be eligible for multiple differentiated service delivery models, which includes the multi-month ART dispensation. So decentralized ART refill at the LAC or co-located TI site, or the OST site, or the CST sites, and formation of the community ART refill groups. And again, the routine viral load testing for them after every 1 year. So package C is basically who are unsuppressed or who are unstable, who are categorized as unstable criteria. So we need to provide additional enhanced adherence counseling, okay, which is 3 months with more than 395% of adherence counseling, and then follow up viral load testing. This is again a point where there is a bit of linkage loss that we usually observe. So people who are unsuppressed, they are missing out on provision of the EAC part of it, and documenting the same Annexure 6 again in the white cards is a major gap, and again following them up for the follow-up viral load testing. So these are the major gaps in terms of provision of services for the unsuppressed patients. So when you talk about these particular gaps, so this is where the focus has to be. A line list has to be generated for these particular patients, and ensure that they complete 3 months of EAC. Okay, the EAC one part of it with more than 95%, and then follow viral load testing. Someone who doesn't fall into this criteria, and then again you go on with the EAC2 part of it and follow viral load testing, and irrespective of the adherence, they have to, if they are not suppressed, then they have to be referred for the SASE part of it. So which is e-referral has to be done, and timely switch has to be ensured by the ART plus centers and the COEs. So patient-centric packages, particularly again when we talk about this particular thing, package who are unsuppressed, then again your key populations of the adults and children and pregnant women come into the scenario. And case management approach for the focused individual care for the PLHF, such as the monthly phone follow-up. Again, you have to maintain the phone follow-up call register, phone follow-up log register. Okay, peer support, and if possible, home visits wherever possible by the CSC staff. And the special care has to be given for those PLHF who return to the care after being missed or LFU. So again, a bit of adherence counseling has to be given for these particular patients. And the CSC will again look into the part of the tracking and tracing for the missed appointments along with the ART staff, and also the advanced disease management. So these are the 4 packages that needs to be provided based on the patient categorization at the ART centers or at the LAC plus centers. So if we actually look at a standard package of service across all the ART centers, so most important is you put your 3.10, which is your 11 ART care, okay, and categorize them. So you look at how many people will fall into this particular category. So one is A plus, so which you have to color code it as A plus, the patients with the yellow stickering. and people who are suppressed with the green sticker, and people who are unsuppressed or unstable with the red sticker. On the right side, you can see one of the good best practices in one of the ART centers, where they have clearly categorized the patients based on the stable and unstable criteria. So the most important point is, if you put your data here and see how many patients are will fall into this particular category, then it gives a clear picture where we need to focus or provide more focused services to the PLHIV. So with the recent data, I think more than any ART center that you take, with the availability of the dolutegravir, even for the pediatric patients, the suppression rates are usually been more than 90 to 95%. So the rest of the 5% is your focus group. So you put this particular table, see how many patients fall into these four categories, then we'll get an idea. So on the treatment, on the programmatic, where my center need to focus on which population, no, which category of the patient that we need to focus, so that no, they all come into the category B, who are virally suppressed and stable patients. So when we look at, is it possible to triage in a high load center? If triage is possible, what proportion you anticipate in category B? So as we discussed, with the availability of the dolutegravir in the national program, and for the pediatric patients, the viral load suppression rates are usually in above 90 to 95% in any ART center that you take. So package B services for the stable pale HIV, so they can be considered for the differentiated service delivery models like your multi-month dispensation. Again, keep this in mind, based on the stock availability, the MMD will be decided. So based on what NACO approves it. So NACO says, yeah, you can go ahead with MMD, please go ahead with MMD. Please do not no exhaust your stocks giving MMD to all the patients. So you look at who are all eligible, can I go for an MMD? So based on that, you can please take a call. Okay, so they can be linked out to the link ART centers, again falling in the criteria of the stable criteria, falling into the stable criteria, and also can be a carb based, community based refill also can be planned for these particular patients who fall into the package B category. So for all patients on first line ART, routine viral load testing, we know that it has to be not 6 months and 12 months after ART initiation, and thereafter annually. And it varies again. So when you say annually, so people who are suppressed, then they undergo annual viral load testing. People who are not suppressed at 6 months and 12 months, as we know, they have to undergo an EAC1 and EAC2, and then follow up viral load testing. And then if not suppressed, again the same, the process of referring to the SASA part of it. So as we seen in the earlier slide, the white cards of PLHAV should be tagged with the green removable sticker, because the patient should be again there in the stable criteria. If at all they go back, I mean, they again there is a viral load, they are not suppressed, then again the stickering has to be changed. Okay, again the color coding of the white cards has to be changed. So talking about coming to the objectives of LAC and LAC Plus, we have seen a bit of background of 2008, 2011, and 2017, where the scale up has happened and the ART initiation has done in the initial slides. So the objective is basically to increase the access of ART to the PLHIV. So and ensure that no, the drug adherence is there, and we ensure that people who are there residing near to these places, or no, the retentions will be high, and ensure that there is no linkage loss between the testing and the treatment services. Okay, so integrating the services with the HIV care support and treatment services with the general health systems, and involvement of the community in the retention of the PLHSC. So these are the major objectives of the LAC and LAC plus centers. So how do we set up an LAC and LAC plus? So these are all again from the national operational guidelines. So you have to identify which site is appropriate, and then you do a feasibility assessment, and then you get an administrative approval so from the SACs and submit it to NACO. You know, for further approvals. So the SACs persons, or the DAPCO, DISHA, or the RCs will be doing then the initial assessment based on the annexure rate of the operational guidelines. And then a team will be formed, and then they do an feasibility assessment, and then they discuss with the medical superintendents there, with the availability of the staff there, and then you see how many people that can be benefited when we start up an LAC at this particular site. So all this will come into, you fill it up in the annexure, right? Okay, and then we submit the from SACs to the NACO that the LAC is being established, and then And then if then LAC plus is being proposed, then the routine, the HR recruitment of the staff nurse will be there, and then you train the staff nurse and the lab technicians, and then the orientation of the whole LAC team. The medical officer is from general health systems, and your ICTC staff will be there, and the staff nurse is one appointed at LAC plus center, and and then start up the LAC. So these are some of the important steps that you plan to set up an LAC and LAC plus centers. So there might be a bit difference in terms of the HR when you talk about LAC and LAC plus center in terms of appointing a staff nurse. And all the officials from SACs and the district authorities will be involved in identifying the sites and identifying the number of people that can be linked out to these centers, and then through the proper channels, getting it approved through the SACs and NACO, and then making it operational. So functions of LAC and LL plus, as we discussed earlier. So the LAC plus is basically a drug dispensing site, and then you monitor the pale HIV and ART. So the staff will be trained on the adherence part of it, the nutrition counseling, and then um, treatment of OI based on the capacity, and depends on availability of the medical officers. They trained experts at that particular center or that hospital. And identification of the adverse effects and management usually depends again on the capacities at the center, depending on the staff, or we refer them back to the nodal ART center. Tracking and tracing of the missing LFU cases, screening for TB symptoms on every visit, and psychosocial support, and referral to the nodal ART centers on 6 monthly basis, or even earlier if needed. So when you talk about LAC plus centers, as we said, that now these are these centers can now actually enroll the patients into a HIV care, and also ART initiations can be done who are clinically stable. Baseline investigations and CD4 testing through linkage to the nodal ART center. Baseline investigations can also be done at that particular hospital if all the baseline investigations are available. But the CD4 testing, again, you'll be linking it up to the nearest nodal ART center for the CD4 testing, and referral of the symptomatic who are unstable patients back to the nodal ART centers for ART initiations. So this is the annexure that I was discussing about. So this is the feasibility assessment checklist. So this checklist has to be followed and signed by all the members of the visiting team. Okay. So you'll also look at most of the factors, especially the availability of the space, and then availability of the medical officer, whether ICTC center, the counselor and technician is there, availability of general investigations, okay, and what other facilities are available, like when we look at whether they have a OPG department, whether they have general medicine, not the departments, at least some experts at that particular level. So if these are available, then no, this particular feasibility assessment checklist will be filled up and submitted to SACs and to the NACO for further approvals. So this is the LAC plus feasibility assessment. Again, as I said, a bit more in terms of availability of the investigations, availability of the infrastructure, and the functioning of the ICTC, number of positives being detected, and whether it was the earlier LAC functioning, it was not a functioning center. So all this, no, Annexure 9 feasibility assessment has to be submitted to SACs and to the NACO for the appropriate approvals. So what are the steps in linking out of the PLHIV to LAC? So once you categorize the patients into stable and unstable criteria, so all your stable patients are eligible to be linked out. So someone who is there in the first line, second line, and third line, or the children, okay, all these patients are eligible to be linked out to the LAC, but with the consent of the patient. Okay. So, but sometimes the patients might not be, giving consent, but at the same time, you also have to, do a bit of counseling. And we have seen such centers where the LACs have been established, but at the same time, since the people were not interested to be linked out, those centers were, left unfunctional, or no, with minimal patients. Like when we say like 100 patients can be linked out this particular LAC center, but the patients are not willing. So hardly a minimal load of 20-30 patients are still there. Are some LACs which are functioning with that minimal load. So the most important point here is convincing the patient to be linked out, and also formation of car group models, so that he doesn't, someone who is not willing actually to go to the center to collect the medicines, at least one of the car members can actually collect on his behalf and hand out the ART medicines. So what are the steps in? So as I said, first is your eligibility criteria. So eligibility criteria of stable and unstable, we'll look in the next slide. So what is the role of the nodal IRT centers in terms of the linking out the PLHV to the LAC? What are the documents that are needed to be linked out to the LAC? What the supply of drugs, what's the amount of drugs that needs to be given, supplied to the LAC centers? And how do you actually keep a track of recording and reporting for the patients who are linked out to the LACs? So eligibility criteria. So as I said, when you link out, so any PLHAV or CLHV on any ART regimen fulfilling the stable criteria. So patient is a resident who is closer to that LAC plus and is willing to be linked out. That's what I said. The patient consent has to be there. Patient should actually be willing to be linked out. Okay. Stable patients on any ART regimen, first line, second line, and third line for at least 6 months, okay, and virally suppressed. And PLHAV and TPT who have completed 3 months on TPT and fulfilling the above criteria. So now it's now no more. It's now talking about the TPT part of it. It's now most of the people will come on the category of 1 HP, right? So people who have completed 1 month of HP or people who are there on 6H. If they have completed 3 months on TPT, so they can be safely linked out to the nearest LAC plus centers. So, as I said again, your LACs are encouraged to provide MMT to stable patients availing services. Okay, but again, it depends on the availability of the stock and the NACO approval. So, when NACO says okay, availability depending on availability of stock, then the patients are encouraged, the LACs are encouraged to provide MMT to these stable patients. And coming to the PLH with poor adherence to ART, maybe linked to LACs in order to enhance adherence and retention on case-to-case basis. Okay, so people who always know regular are giving a reason that coming all the way to the ART is difficult. So those people with less adherence can be counseled and then linked out so that ensuring that they are adhered to the treatment and are retained in the program. So again, rigorous follow-up mechanism for these PLHAV at LAC should be ensured, and monthly telephonic follow-up by the ART center regarding these patients, whether they are collecting pills on time or not. So coming to the definition of the stable patients, adolescents more than 10 years, so who are there on ART for more than 6 months without any adverse effects of ART. So there is no current illness or there are no opportunistic infections and there are no medical conditions. So the patient is virally suppressed and CD4 count is rising, exceeding more than 200, and adherence is more than 95% consecutively over the last 3 months. So this is the criteria when we talk about stable patients for adults and adolescents. So they should be virally suppressed. They should be more than on ART for more than 6 months and CD4 count more than 200. Adherence more than 95% in the last consecutive 3 months with no OIs and no current illness and no other medical conditions. Coming to the children on ART for more than 6 months who are suppressed, okay, and treatment adherence is more than 95%. And the most important, they should be on the same regimen with no dose or formulation change for at least 3 months and with no current illness and medical conditions, including malnutrition. Okay, so it is basically any patient who are on any regimen, whether first line, second line, and third line, can be linked out to the LSs. Okay, if they are on these regimens for more than 6 months, right? So as I said again, PLHAV who have completed 1 HP can be linked out. Okay, people who are on 6H regimen who have completed 3 months of TPT, they can also be linked out, but provided proper counseling and adherence on and the adverse effects for the patients. So what are the documents and what are the prescription that needs to be done? So once it has been decided that the patient is ready to be linked out to any the link ART center, so the nodal ART center will be counseling the patients and providing information about the LAC, the contact details of the LAC, where the LAC is located, and 1 month ART is being dispensed so that at least patient will have 1 month of time to go and report back to the ART center. Okay, so the ART, the current regimen, it will be prescribed for 6 months of drugs to be refilled from the LIC. So only the patients from designated nodal ART center shall be linked out to the linked attached LAC plus center. Okay, and patient should be linked out to LAC through SOCH. There is no need to maintain link out forms as it was a practice in the old times. So prompt will go in search to LAC whenever the pale HIV is linked out, and the original patient booklet, the green booklet, green book with the details of link out, address and contact of LAC are to be given to the pale HIV during the link out time. So white card has to be maintained at both the centers, which is marked as LAC copy and the ART center copy. And the card is to be updated based on the information received from the nodal ART center, LAC and LAC plus center. So nodal ART center shall report about the total patient linked out to the link ART centers in the monthly reporting format. At any point after, the most important is that LAC will not initiate or modify ART in any patient at any point after. This is the most important. So LAC should not initiate. It will not initiate or modify ART, right? So referral of on ART patients from LAC plus to nodal ART center. So when do you actually refer back from LAC plus to nodal ART center? So which is called as a LinkedIn to the nodal ART center. So routinely once every 6 months for a repeat viral load testing or a CD4 testing or a comprehensive clinical review or for the general investigations. Okay, but the patient should be sent at least 1 to 2 weeks before the ARV refill date to the nodal ART center. So in case if it has to be done before 6 months, if there is any need, like any OIs have been diagnosed or suspected, then they will be referred within 6 months. And if there are any major side effects, there are medical conditions or pregnancy, you have to link it back to the nodal ART center. Okay. There are unstable unsubscribed PLHV who completed your step-up counseling and have 95% adherence for 3 consecutive patients, 3 consecutive months. So they have to be referred back for the further for the SASEP opinions. For LAC outside the health facilities, PLHV who are 4 is positive or have any minor OI or adverse effects can be referred within 6 months. Routinely, it's basically once in 6 months, the patient is stable, or anytime before 6 months if any of these conditions are met. So what are the documentations for LinkedIn? So when the patient is referred back to nodal ART center, he should be carrying the following documents. So LinkedIn to the nodal ART center through search, no need to maintain LinkedIn forms. A prompt will go in search to the ART center where the PLHV is linked back to the nodal ART center. And the following details to be given the PLHV LinkedIn. So the patient green book has to be sent it back with the patient with details of LinkedIn address and the contact details of the ART center. And white card photocopy or and a scan copy to the ART center has to be sent for the LinkedIn process. So what activities need to be done at the nodal ART center? So it will be once the patient is linked in, the following activity shall be done on the nodal ART center routinely for every 6 months. So if the patient is coming after 6 months, then clinical review, the 4S screening has to be done. General investigations have to be done if there are any pending investigations, and the viral load testing, CD4 count. Okay, and then the drug refill shall be done from the ART center again for the 1 month when the patient is linked in. So if at all there is a need based on modification, there is a need for the modification, then it has to be modification of the drug regimen. It has to be done. Then if there is a substitution or switch, then they may be linked as soon as they're considered stable. So again, you have to fill up the ART copy of the white card from the photocopy or electronic copy of the white card and the green booklet. In case of the patient is retained at the nodal ART center, the information of the same should be provided to the LAC or LAC plus center. So suppose the patient is unstable or the nodal ART center, medical officer feels that the patient has to be retained back at the ART center, then it has to be conveyed back to the LAC plus center. So coming to the standard operating procedures for the ART initiations at LAC plus center. So once the patient is enrolled into the HIV care and ART initiations at the LAC plus center, so once the patient is detected positive at the ICTC center, so then the enrollment will be done at the LAC plus in the same day. So the patient will be screened for the OIs and then and the STIs and any other comorbidity. WHO staging will be done. Okay, so initial workup, baseline investigations available, if available, at that particular center has to be done. Preparedness counseling, documentation, and in the HIV care register, white card and green book will be done. So the patient is symptomatic, diagnosed, and there is a need for the referral to the nodal ART center. Then the patient will be referred to the nodal ART center for further management. The patient is stable, asymptomatic. So the preparedness counseling will be given, address verification, identification of the family care member or caregiver, and the TPT prophylaxis and the CPT prophylaxis eligibility criteria will be checked, and if eligible, that will be provided. ART initiation is will be done. Okay, enrollment in the ART register. follow visits every month and assess for the side effects on every visit for adherence, and then screening for the 4S and OIs for on every visit, and then discussing more about the positive prevention and reporting in the SOCH. The most important is the HIV care number will only be issued by the nodal ART center telephonically and in SOCH after registering the PLHIV. One copy of the white card will be maintained at the nodal ART center after issuing the HIV care registration number. Patient tracing in case of miss and LFU will be done at the LAC plus. Okay. And as I said, for the centers identifying LAC plus centers to initiate the ART, the most important point is that the staff has to be trained. The medical officer has to be trained on the NACO ART MO modules. Okay. So before initiating ART, ensure that the training is completed for all the staff, especially the medical officer, on the ART MO modules. So baseline investigation, as I said, it has to be done through the general health system. Okay. Staff nurse, LAC plus as the designated staff nurse will be referring the patient for the baseline investigations. CD4 testing sample will be collected and sent to the nodal ART center for testing. Okay. The ICTC-LT or the staff nurse will be collecting the blood sample for the CD4 testing. Okay. And then the baseline workup for the ART initiation and the OI, the ruling out the OI shall be done at the LAC plus by the medical officer, who is basically from the general health system. If the facilities are not available at the LAC plus, the investigation may be done at the nodal ART center. Okay. But again, the follow-up, most of the centers usually how the general health system, general investigations at the general health systems. But for the CD4 sample collection, there is a bit of a delay in terms of sending it on the same day or at least on the second day part of it after collecting the sample. So this has to be ensured because the CD4 baseline is the most important. So this has to be ensured, at least the sample transportation has to be ensured by the LAC plus center. So the PLHV who are initiated an ART at LAC plus center, so the date of preparedness, the date of initiation will be recorded in the HIV care register and patient will be registered at the ART enrollment register. For those people whose baseline investigations are below the normal parameters, so they should be called back to the LAC center as soon as possible, and if necessary, the medical officer will make necessary adjustment in the ART regimen or refer the patient to the nodal ART for further management. And the information related to the registration initiation of PLHV at the LAC plus shall be shared weekly with the nodal ART center through SOCH. And as I mentioned, that nodal ART center only shall issue the ART number after enrolling the PLHV in the ART enrollment register. Patients initiated LAC plus would be followed up on a monthly basis at LAC for the treatment and laboratory monitoring. And the follow-up CD4 viral load testing will be done at the nodal ART center during the regular 6-monthly visits. So every patient registered at your LAC plus center will have to be sent to the nodal ART center at 6-monthly basis for further follow-up of investigations for routine checkups and CD4 and viral load monitoring. So PLHAV who cannot be initiated at the nodal ART center, at the LAC plus center, will be referred to the nodal ART center. And in the HIV care register on the remarks column, the staff nurse will record the status as referred to the nodal ART center. So when the patient is referred to the nodal ART center for the management of ART initiation, so the patient will be given the following documents. So patient should be linked in to the nodal ART center through SOCH, and original patient booklet, green book, and with the reason for the link in along with that is the contact details have to be mentioned in the green book. So referral to the when do we refer the patient to nodal ART center? Patient may be referred to nodal ART centers if at all there is any OI, there is a TB or not manageable at LAC plus centers, there are other adverse effects or other medical conditions. Okay, CD4 and viral load testing as per the guidelines. So every 6 months and then initially and then after 6 months and then after every 1 year. So for the management of the treatment failure conditions and there are any adverse effects or complications, patients who are poor adherent and not manageable at LAC, these patients will be referred to the nodal ART center. So the nodal ART center should include all LAC plus patients initiated an ART as well as a non-ART as the nodal center patients for reporting in the MPR. So regarding and reporting, so the At LAC, your section 1, 2, 3 are to be completed by the counselor and the staff nurse. Sections 4 to 13 are to be completed by the LAC medical officer. So patient booklet, it is to be filled by the staff nurse, counselor, and doctor during every visit. Stock register to be auto-generated from source by the pharmacist or the staff nurse. So when the drug dispensation registers to be auto-generated from source by the pharmacist or staff nurse. So the most important for the nodal ART center is whether your LAC plus centers are utilizing SOACH on a daily basis. So that is most important. And most of the times that we observe during our routine visits is LACs and LAC plus centers, most of the times they don't do it on a daily basis for some reasons like non-availability of the internet, non-availability of the system, okay, or the staff is not trained on the LAC modules of the SOACH. So these are some of the challenges that we usually see. So these needs to be addressed by the nodal ART center. So they have to mentor and monitor the LAC plant centers in terms of using the SOACH on a daily basis. And in addition to recording and reporting tools maintained by LAC, the following tools will be maintained for the PLHAV registered in HIV care at the LAC Plus Center. HIV care register, which is same as the HIV care register of the ART centers, which is to be filled by the staff nurse. CD4 sample transport register to be maintained by the ICTC lab technician. HIV line list and HIV TB register to be generated from SOACH. So it's always better if at all there are issues in terms of SOACH usage. So for you to upload the necessary data, at least the hard copies have to be made. HVTB line list and HVTB register have to be maintained at the LAC plus centers, even though generated from SOACH. So as I said, there might be challenges when we talk about the LAC plus centers, which are most probably in remote areas where certain facilities might not be available for the staff to do the work on a daily basis. And the white card has to be maintained both at ART and LAC centers, marked as LAC copy and ART center copy. So you have to ensure the availability of the ART drugs at the LAC plus center. Ideally, at least 3 months of stock should be available for the PLHAV at any given point of time. So how do you basically calculate for LAC? You have to look out number of people PLHAV linked out, okay, to the LAC plus centers plus your 3 months into 3 months of stock plus 1 month of buffer stock has to be calculated. And for the LAC plus center, in addition to the above, LAC plus will also give received drugs to the ART initiation for the new PLHV. It depends on that particular LAC plus how many positives, assuming that the number basing on the number of the positives that can be detected at your LAC plus center. So in addition to the routine drug stock, so additional stock will be given for the LAC plus center along with a 1 month buffer stock. PLHAV already on MMD are expected to be on MMD to be considered when you calculate the stock. Already on MMD, that number also has to be taken into consideration. So the drug transportation mechanism, as per the NACO guidelines, so will be supplied based on a quarterly basis. Okay, so the pharmacist or the nodal ART center has to cross-check with the SOACH and recommend for approval of SMO or MO or in charge of the ART center. So the drugs will be transported to LAC through LAC staff or by the health system staff, vehicle or through the courier agency or supply chain management agency. The cost which will be borne under operational cost as per the NACO guidelines and TADA as per the NACO guidelines. Drug stock reporting, the nodal ART center shall not deduct the total quantity of drugs transferred to link ads in the monthly report. Deduct the drugs actually dispensed to the patient at LAC plus during the month as reported in the monthly reporting format. SOACH entries, pharmacist of nodal ART center to report stock in the SOACH as soon as stock is given to the LAC. LAC staff update dispensation SOACH on a daily basis. As I said, this is most important and we do come across challenges, but somehow these challenges have to be overcome and ensure that LACs also utilize the SOACH on a daily basis. LAC in charge should physically verify the stock of all ARV drugs every month and cross-check with the SOACH and MPR and sign in the stock register that we actually do in the stock verification register at the nodal ART center. SOACH and LAC monthly reporting, the login will be created by the nodal ART center for LAC and LAC plus center. So as I said, the nodal ART center staff will conduct an orientation and mentoring of the LAC staff on SOACH. Thus, drug dispensation has to be done by the pharmacist, staff nurse, or the counselor, and which should be recorded in the SOACH on a daily basis. For any unavoidable circumstances, if such entry is not possible, then Form B for LAC and Form C for LAC plus centers needs to be continued. As I said, the hard copies need to be maintained in case if there are any challenges in terms of soch entries, then your Form 4B for LAC and Form 4C for LAC plus has to be continued. And real-time data entry should be shared between nodal ART center and LAC plus center. So it is the responsibility of the nodal ART center to ensure that your LAC plus utilizes the search on daily basis. I mean, they enter the data in search on daily basis. MBR will be for the LAC plus will be auto-generated in search and which will be accessible to nodal ART center also. Your LAC plus download the MPR and maintain a hard copy, soft copy for their regular use and for the program monitoring. So when it comes to the utilization of the search by LAC plus centers, there are many challenges, but it's up to the nodal ART center and the LAC plus centers to ensure that no, the challenges are addressed and no, these centers utilize. And the community ART refill groups are this is again as per the NACO guidelines. So the CAR groups are self-forming groups of stable PLHAV from the same geographical area. Example, adolescents only or family units or community groups or networks are members of a specific key populations, which are managed and facilitated by the PLHAV themselves. Community members of peace or PLHAV networks, CSCs, CBO, TA NGOs, link workers, or any other providers. So these groups will be formally registered at the ART center along with the details of the focal person and all group members. So this is again one of those the differentiated service delivery models. So LAC plus centers and formation of the car groups, decongesting the ART centers and no provision of the services and at their the nearest home places. So these are the some of those differentiated service delivery models which can be implemented, and one of that is your community ART refill groups. So the SOP is basically how for forming a car model is you identify a group of people within that particular locality by the RTC counselor, and you identify a focal person who can represent that particular group. Okay, so that the persons usually on a rotation basis will collect the medicine from the ART center. Okay, and they'll also be trained on the group counseling, the adherence part of it, or for symptom screening of the other group members. Okay, and then when they come back to collect the medicines, counselors update the records. So all the members will visit at least once in 6 months for, as I said, for the routine checkup at the nodal ART center, and the follow-up mechanism will be done by the ARTC center. So SOP for the community ART refill groups is this can be formed by the community itself based on common need for care or geography typology. So ART counselor can identify and support the formation of these groups. The number of members may vary based on local context and may be smaller in rural and hard to reach areas. These groups will be formally registered at the ART center, and they should be willing to be part of the community ART refill group. All the members who are willing to be part of this particular group, they should also be willing to disclose their status to each other and should be fulfilling the criteria of stable PLHAV. However, in case on a case-to-case basis, non-adherent PLHAV may be considered. Okay. So the main focal person who will be acting as a link between the ART center and the car group. Okay. So the group members can take turns to be the focal person. However, other members of the group should not be charged, okay, for collecting the medicines. And one member from the group on a rotation basis can collect the ARVs from the nodal ART center. But at the same time, providing as I said, the adherence has to be discussed with the group, and for symptom screening or any other problems are there. So that should be brought to the notice of the nodal ART center. Counselor shall follow up the CARG at the ART center, visit for the adherent status of the CARG members and any action required for any other CARG members. The counselor shall also update the adherents and other relevant details of the members in their original white card and other records during each visit of the CARG representative. But it is ensured that each member of the group visits the ART center at least once in 6 months for the clinical consultation and other necessary investigations like CD4, viral load, general investigations. And the ART center should call the PLHU to the ART center if they're due for the clinical consultancy in case no, they don't turn up for viral load testing or CD4 or no, for SAS, other substitutions or switch. So what are the responsibilities of the car? So they should ensure a timely pickup from the ART center and refill for all the members of the group. Monitor adherence of the member, document the same in the relevant tools and registers, provide peer counseling and verbally screening for four symptoms, referring them for the ART center on a 6 monthly basis for the clinical and laboratory assessment, and the coordination between the ART center for the effective and smooth functioning of the car group. So the car members' responsibilities will be, maintaining good adherence, timely pill intake, and then informing it to the focal person, attend attend any group meetings that were that will be convinced by the car group. Visit the ART center, represent the group as per the schedule, and undergo clinical and laboratory investigations. And in case of any forest symptoms, OIs, or any other adverse effects, informs the nodal focal person and schedule a visit to the ART center at the earliest. So this is in brief about the services to be scaled up at LAC and LAC Plus Center. Some of the key points is all the stable patients, irrespective of the regimen, first line, second line, and third line, if they are categorized under stable category, they can be linked to the LAC, LAC Plus based on the consent. And the patients will still be continue to be patients on all ART centers, and white card has to be maintained both at both the centers, marked as LAC copy and ART center copy. Screening and documentation of the TB symptoms on each and every visit of the patient. LAC staff should update dispensation in SOJ on a daily basis, and all PLHIV diagnosed positive for HIV can be initiated on ART at LAC Plus Center unless if there are any major voids. Training, mentoring, and monitoring of the LAC is the responsibility of the nodal ART center. Nodal ART centers are expected to make regular visits to LACs to support LAC, LAC Plus Center. At least take out some time, at least in a month, plan to visit one LAC or LAC Plus Center and provide, try to address the gaps that are there at the particular center. Formation of the community ART refill groups. Again, this is a decision has to be taken at the district level and the SACS level. Okay. Routine viral load testing as per timelines. So patients who are registered at LAC, LAC Plus centers have to be sent to the nodal ART at 6 monthly basis for routine timely investigations of CD4 viral load and general investigations. And the screening for Hep B and Hep C in coordination with NVSCP has to be done both at ART, nodal ART, and LAC and LAC Plus center. And along with that, the NCD screening also has to be implemented at LAC, LAC Plus screening for diabetes, hypertension, CS weeks, and mental health in coordination with the district NCD cell. So these are some of the key points, and with this I come to the end of the session. If there are any questions, we'll be willing to take.
Thank you
you
so much, sir. There are no questions in the chat box. Kiran sir, can we please give mic access to everyone? Requesting participants to please unmute and ask questions. Dr. Tripathi sir.
Ravi,
Yes.
I have posted the question in chat box, but I am telling you verbally that when you discuss about the stable criteria of the patients in case of CLHIV, there is a mention that there should not be any dose change and regimen change during the last 3 months.
Yes, sir.
So, if during the last 3 months, my question is, if the child has changed his weight band to higher side, shouldn't we change the, shouldn't they modify the dose?
Modify the dose, sir. Modify the dose. There is no problem at all in modifying the dose. But what we said is, if there is a dose modification, so patient immediately should not be linked out to the LAC, because we need at least 3 months of time or till the viral load testing is done, whether the patient is suppressed or not. So why do we actually look at dose modification based on the weight band, right? So once we do the weight band modification and the dose is adjusted, we also need to monitor whether the child is suppressed or not suppressed. So that's the reason we say, if there is a dose change or formulation change, for at least last 3 months may change over, then we say that please wait for next 3 months or 6 months till we do a CD4 viral load testing, and then the patient is suppressed, then we plan to link out. Clear, sir?
But we should change the dose if the weight band has changed. Otherwise, it will be low dose.
No,
And
that's what I'm saying, sir. If the patient is on the same regimen, okay, suppose we do a dose change, then we don't actually link out the patient. That's the meaning of this particular sentence.
Okay, thank you.
Thanks, sir.
Any more questions? Participants can unmute now.
I can just reiterate that the patient should the center should actually do the categorization based on this particular table, okay, and categorize them into these four labelings, so the color codings, and then see where your center stands. That's the most important thing. You put your patients under A plus B and C, and see where you have to focus. Your focus will be more majorly on unsupported unstable patients, and your focus will be on the newly initiated and ADM patients, because newly initiated patients should not be missed out or LFUs, and they should be virally suppressed within that 6 months of period after ART initiation. That is your focus. Your ADM patients who are less than CD4 count 200 and with other OIs, so they should be given focus. And as I said, any center that you take, you are more than 90% of the patients will be viral, 90 to 95% will be virally suppressed. So the focus will be on your A plus and C, which will be around 5 to 7%. So that is most important. So categorize the patients. That is most important.
Dr. Ravi, my
Yes, sir.
question is, please show the questions in the chat box and discuss one after another.
There are no
These questions are not
questions.
visible.
That's what I heard from Sweta ji. देख लो क्वेश्चन सही क्या?
जी नहीं questions नहीं है sir. Tripathi sir, I thought it is a comment from you, so I did not place it. Okay.
Yes, ma'am.
Yeah. So any timeline of meeting with nodal officers at LAC plus. Sushil sir, if you can please unmute.
There are no questions, sir. आपका ही एक क्वेश्चन है इसमें. त्रिपाठी सर, आपका ही एक क्वेश्चन है, बाकी सब तो क्वेश्चंस नहीं है.
Good afternoon, sir. This is Dr. Sushil.
Yes, sir.
Yes, sir.
I wish to know, is there any specific timeline between the MO at LAC Plus and MO at ART Center for some meetings?
There is no as such timeline, sir, but what we say is at least a quarterly visits have to be made. Okay.
Okay.
So again, you also look at whether the center is performing or not performing. So the priority will be the LAC plus center, which are low performing. So the focus can be on those centers rather than good performing center. And as you rightly said, so they can actually arrange for a call. Every monthly meeting also they can arrange for a call. Virtually, they can connect and discuss. So that's one of the good practices that we have seen in some of the states, where they connect with the Nodal ART Center, will connect with the LAC Plus Center on a monthly basis and discuss on one-to-one if there are any challenges that needs to be addressed. So that can be implemented. So that there is no timeline as such, but you can go ahead with having interactive meetings on need basis or at least on a monthly basis.
Thank you, sir. Thank you.
Thank you so much, sir.
Any more questions? Participants can now unmute and ask questions.
So if any state is also again planning for the scaling up of LAC plus centers, please do keep in mind that the staff at the LAC plus center who are all from the general health system have to be trained on the RTMO. So just do not directly get the approvals and then start initiating the ART at the ART centers, because we know in the general health system that the staff keeps changing. So because since the LAC plus centers usually the medical officer is from the general health system, there is a possibility that they might keep changing. So ensure whoever is changed, again the training has to go on with the approvals of SACs, keeping SACs informed.
Excuse me, sir. I am a medical officer from Gulbarga, sir.
Yeah, ma'am. Good afternoon.
Good afternoon, sir. So my question is, since the criteria for stable patients is changed, it was only first line before. Now it is first line, second line, and third line as well.
Yes,
is the supply of those drugs to the LAC centers also from now on?
We can do it, ma'am.
Because I've been.
This as per the guidelines, so we can go ahead.
So it will be starting from now onwards, sir. Is it so?
It's been there in the guidelines since 2021, ma'am. So anyone stable criteria, because previously, as you rightly said, only the patients on first line were supposed to be linked out, and that was before 2021 when the guidelines didn't come. So once the 2021 guidelines, operational and treatment guidelines have come, patients on any regimen, first line, second line, and third line, who are stable, who actually meet the criteria of the stable,
Yes, yes, sir.
so they can be linked out, ma'am.
So the procedure will be, I will be mailing the patient details to the SACs to send the tablets to relocate it to our center or directly to the LAC, sir.
You can relocate it, ma'am, because the patients will be from your nodal ART center.
So we
First
have
line,
to
second
add
line.
on to the requirement.
You have to add on to the requirement and send it
Okay,
to the nodal ART, because the drugs will only be coming to your center. So you will be dispatching it to the LAC, LAC plus centers.
Yes, sir. Okay, sir.
Okay, ma'am. Thank you, ma'am.
Yes, sir. Actually, I have one more doubt, sir, but it is
Yes,
not
ma'am.
related to LAC.
No problem, ma'am. Please
It's
ask.
related to the centers. Mine is a nodal center, and
Yeah,
I cater to the needs of Yadgir, Jewargi, and Bidar as well.
Okay,
I
ma'am.
have few cases whose because they are on TLD, there's renal toxicity, and I've switched them to abacavir based regimens, sir.
Okay, ma'am.
So that abacavir 600 mg, 300 mg tablets and plain lamivudine 100 mg tablets are available only in my nodal center. It's not available in Yadgir and Bidar, even though they are ART centers, sir. So the patients are finding it very difficult. I have about 5 patients from Yadgir and 3 patients from Jewargi coming to my place, and they're complaining about travel issues. They're not able to stick to the adherence because of the travel problems, sir.
Okay, ma'am.
So
So maybe you can, you are the right person to, you can actually, this is a very good question. So we can actually discuss how do we go about it. So
yes,
how do we go about it? So one is,
I think
one is the patient is stable. The patient is, once you change, because of the toxicity you had substituted with ALD, right?
yes, sir.
So, and then the patient is now stable. The viral load has been done. Viral patient is suppressed.
Yes, sir.
The patient is suppressed. The patient is stable. Then one option is dispensing. If you have enough stock of these particular drugs, MMD is one option.
Okay, sir.
And dispatching the medicines to the nearest center is the second option. And third option, as I said, is formation of the car group, which might not be go well with some of the patients, but this is another option. So there are 3-4 options that we can look at and discuss with the patient and see which is best suited for the patient.
Can be transferred. They want to take it in the same parent wherever
Link out. You can link out, ma'am. You can if it is an ART, then you can transfer out, ma'am. So which is to the nearest or the patient's convenience. So discuss with the patient, talk with them, which are the nearest centers to them.
Okay, sir.
But ensure the patient is stable.
Yes.
CD4 is good, viral load is good, patient is no adverse effects now.
Yes.
Then only you can take a call.
Okay, sir. Thank you
and
so much.
adherence is good.
Yes.
Thank you. Thank you.
Thank
So
you.
much.
So there's a question in the chat box. Can the
Yeah.
grade criteria be included in the monthly reports?
Sorry. Which
Can the
criteria?
grade criteria, I think ma'am is talking about the categorization. So stable,
There
unstable.
is which question? Can the grade criteria be included in the? No
Monthly
need.
report.
There is no need. There is no actually column for you to put the grades there. In the monthly report that you look at, there is nothing like a grade which can be captured in a monthly report. Grading is for the benefit of the ART center, for you to look at how many patients in my center are stable, how many patients in my center are not stable, how many patients are newly
Good
registered, how
afternoon,
many.
sir. Good afternoon, sir.
Yes, ma'am. Yes, ma'am.
Yeah, doctor speaking from Belgaum.
Yes, ma'am.
What I meant by the grade criteria is your A plus, B, and C.
Yes, ma'am.
So this, if it is regularly, it is a form
Okay.
of assessment. If it is done in the, not either in the MPRs or any other reports, the center as well as the headquarters will have an idea how the center is performing.
Absolutely, ma'am. Very, very good point, ma'am. Very good point.
This it
So,
can be regularly done or enforced.
excellent, ma'am. Excellent. So this is basically at the level of a district, at the level of center, at the level of state,
Yes.
SACS level. So some of the SACs usually do this particular grading. Okay, I mean, look at where my centers have how many A plus and B and C criteria. That's what I said. Is it possible, if you look at this particular side, is it possible? I'll just close this 1 second, ma'am.
We can always do at our level, but
we can always do that,
but
ma'am.
whenever it is told by the higher authority, there will be a pressure on us
th-
to keep it up.
Yes, ma'am. So again, health is basically a state subject. So when we talk about our own ART center, like some good initiative medical officers are actually doing this particular part. Okay. And the states also looking at that part, even district at the district level, if they have 5, 6 ART centers, they're looking how many centers. I mean, what is basically the status of my centers, how many are stable, how many are unstable. So this is a good thing for any state or any district basically to. So is it possible to triage a high load center? So definitely we can do that. Okay. And we can categorize the patients, and this gives us where we actually can focus on which group that we can focus. As I said, 90% of the patients will be virally suppressed. They will be in C. So
Yeah,
they will
yeah.
be in B.
Yes, sir. Yes, sir.
And you hardly have new patients which are under A plus, right? Or
Yes.
A plus may you also have people who are already on ART and less than CD4 who are in the ADM criteria. So A is your only new patients. You have very few new patients. So this categorization will definitely help the ART centers to prioritize the services for the PLHA. ठीक है, ma'am? Yeah, any other questions? Sir?
So there is a question. What are the issues and challenges in CARG, Community ART Refill Group?
Issues and challenges is basically, I can say, because very few states have implemented the CARG, even though there is no clear-cut guideline and permissions from NACO to formation of the CARG. So issues will be identifying the group, and the group has to agree that will be will be part of this community ART refill group, because the stigma and discrimination is one major thing, and the status, knowing the status for other group members within that particular area is one more thing. So identifying a strong group, who will agree to be part of that particular CARG, and then ensuring that they also participate, maybe in once in a month they meet once in a month in one of those CSE or somewhere else. So I can say most important issue could be the identification and acceptance from the community itself to be part of that particular group. And challenges, I say, like the rotation basis, one person coming all the way and collecting the medicine on behalf of the group. Okay. On rotation basis, another person has to come. Suppose he is not willing, then you have to identify another person. So who is the leader? As we say, identifying a focal person, that person will have to coordinate. So that's one more challenge. And when we say monitoring them for adherence, so we ensure that, because the CARG can only be formed for the stable patients, right? And once we tell them, okay, you can come after 6 months, आपका जो 6 months का medicine है आपके पास है, okay, then there is a possibility that adherence might actually a difficult criteria for us to monitor. Okay, so that's one more challenge. And the symptom screening, forest screening, or any other OI screening, basics we actually orient the CARG members, the CARG group. Okay, we only train them when they look for these things. Forest, you look at forest, you look at some skin conditions, you look at the patients suffering with no diarrhea and all minor things. So monitoring this particular group by that focal person and bringing it to the notice of the nodal ART center is again one more challenges. So there are always these issues and challenges when you talk about CARG. So when you talk about forming a CARG with the KP population, I can give one of the best example from one of the states. So the female sex workers have come up with starting a CARG with their own center, and from the, I mean, actually LAC, I can say LAC, which was now we can call it as a community ART refill group. Okay, because this is for that community. Okay, and initially it was started with 300-400 female sex workers who are positives, and then now the best part is that as now is one of those busiest LACs, which have around almost near to 800 to 1000 PLHA accessing that particular LAC. So this is again a model of maybe extended model of a CARG So initially it was a car. That time it was the car model was not there. We have to start an LAC. But now I can say that's one of those good examples. So car can be formed with any populations from that community, whether CSC, I can tell you CSC can be a car, right? CSC can take responsibility of the PLHV in those particular areas and can form a car. Okay, but definitely initially starting up is important, and later how do we overcome those issues and challenges will be the second part of it. We literally put it down on paper and see what can be done, how best we can provide the services.
So, good evening, sir.
Yeah, ma'am.
Yeah, PLD regimens are usually given to the LACs. We don't give abacavir and zidovudin. That we should think of giving. The other thing is the modified regimens cannot be given to the LACs because they need regular monitoring of the RFTs.
Ma'am, that's the criteria that we said. Who
Yeah.
belongs to the stable criteria? If
Yeah,
the patient,
yeah,
if
yes,
the medical
yes.
officer is
Yes, sir. Yes.
satisfied, then only he can be linked out. The medical officer is not satisfied, then the patient cannot be linked out
Yes, yes.
unless there is a need. The other question is, what is your opinion on changing the color of A plus grading? I didn't get this. Okay, changing the color of A plus grading. SNACO has given in the guidelines that A plus categories will be sticked with yellow because those are the new cases in patients with ADM. So that needs one color coding. There are only 3 codings that were given by NACO. So we only follow these 3 usually. So as of now, maybe we can take it as a suggestion and bring it to notice of NACO A plus color different coding. Yeah. Forest screening and weight recording are issues in CARC. Definitely, that's what I said. The CARC members have to be oriented in what needs to be done when you form a CARC. So as I said, forest screening and weight recording, this is one of those when we say orienting the CARC members. So the ART center will be orienting on what needs to be done with the CARC members. So because they will be coming once in 6 months for the routine investigations unless there is a need. So forest training every month, that's what I said, the CARC should agree because there are certain guidelines. If you look at the CARC guidelines in the operational guidelines of the NACO, it clearly says that they should hold some support group meetings every month. Then they discuss about all these. That's a place where there is a chance of doing forest training or discussing about adherence, discussing about weight part of it, nutrition part of it, benefits part of it. Yeah, sir. Definitely there will be some challenges, I can say. For sure, agreed on that. But there are also how we deal with those challenges when we form CARCs. So Tirupati sir, Anandrao sir, okay. The
Yes,
question
so
was
there's
from
one
Tirupati.
question.
10S okay. Maybe challenges are more in LAC and CARC. Absolutely, 10S is being implemented by NACO. It will be rolled out soon. And again, challenges as I said, when we say 4S is being implemented at LAC Plus Center, the LAC Plus staff also will be trained on 10S. They have to be trained on 10S. Okay, so let it roll out. There are again will be challenges initially once the staff orientation is done, and we'll see how it goes up.
Yeah, so there's one question. Is there a limit for LAC centers to send only this many of clients? Most of the centers are not taking. I think this is regarding linking out PLHAV to the LAC centers. Jitendra sir, if you can please unmute.
Yes, sir. Jitendra sir, can you please ask? There is no, if at all, if I can answer that, there is nothing like a limit for LAC centers or LAC Plus Center to send this much of clients only. There is nothing, there is no guideline written on that this is the limit. Okay. But look at what services are, what are the difficulties for the LAC centers there. And you think that LAC has reached a certain load, then always there is a possibility that that can be upgraded as an LAC plus center. Okay, so that needs to be discussed with SACs and a call can be taken accordingly. But as such, for this question, there is nothing like a limit for the patients to be linked out. Only thing I can say is that you have to look at the services that are available, the staff that are available, and if the load is beyond the control of that particular center, then that can be upgraded as an LAC plus center, and additional staff can be recruited there as per the guidelines and with the approvals of SACs and NACO. Yeah, I think the question is answered, sir. Jitendra sir.
Any more questions? We'll wait for another 5 minutes to take up
Yeah.
questions. Please feel free to put your questions in the chat box, or you can also unmute and ask questions. Yeah, Jitendra sir has replied that the answer is okay.
Okay. Yeah, then thanks, sir. There will be issues, sir, when you talk about linking out. There will be resistance from the LAC centers because, as I said, availability of the resources at that particular center. So, suppose if you are referring to an LAC center, we assume that there is an ICTC LT and ICTC counselor, okay, and at least a medical officer from the general health system. And suppose we are referring to these centers where where there is only one LTR, there is only one counselor, there is no medical officer. Definitely there will be burden and there will be resistance from that LAC center. So which needs to be discussed with the state or DAPCO, Disha, district authorities and see how we can address this particular thing. Maybe till such time when there are no resources or when we transfer out, there is no counselor, there is no LT, then definitely there is a problem. So look at what is available. How do we go about it? As such,
That's all.
upgrading to LAC plus. Yeah, upgrading to LAC plus is our option.
Yeah, no more questions, sir. We just quickly run the feedback poll. Kiran sir, can we have the feedback poll?
Thank you, everyone. Thank you for the patient listening and sparing your time to attend this session.
Thank you so much, sir, for facilitating this important session. Requesting all the participants to please attempt the feedback poll. There are 5 questions in all. Scroll through the questions and click on the answer of your choice. Please read the last question carefully. Requesting everyone to please attempt the feedback poll. Kiran sir, we can end the e-poll now. Thank you to all the participants for patient listening and active participation. We'll conclude the session now. Thank you, sir.
Thank you. Thank you so much. Thank you, everyone. Thank you for the patient listening. You can always post any questions if there is the group. So any clarification that you need, not in just terms of this particular session, but anything technically, programmatically, you can always post the questions in the group. So we'll be ready to answer. Thank you so much. Stop sharing.
Thank you, everyone.
Thank you. Thank you, Swetaji. Thank you, Kiran.